In this video, we'll discuss the post-operative diplopia test. Now, this is a test we use to give us an indication of the likelihood of diplopia after strabismus surgery. So it's a preoperative assessment, and it's very similar to mapping of the suppression scotoma. However, we're not that interested now in knowing the full length of the suppression scotoma. Rather, in this particular test, we're interested specifically on what would happen with an undercorrection, a full correction, or an overcorrection of the deviation. Now, because it is very similar to mapping of the suppression scotoma, the procedure is very similar. We have a prism before the deviating eye, we increase the prism in strength, and we ask the patient to tell us when they have diplopia. Now, if they're struggling to communicate that, you can use red-green goggles to assist them in appreciating the diplopia as well. Okay, the difference here now between mapping the suppression scotoma and the post-operative diplopia test is that when we map the suppression scotoma, we use both a base-in and a base-out prism so that we can measure the entire length of the scotoma. That's for a horizontal deviation. In this instance, however, it's not necessary to use both prisms. All we want to do is move towards correction because that's what surgery does. It tries to correct the deviation. Let's have a look at that with a projection diagram. So here we have a left ET depicted of 30 diopters. So we have a distance between fovea and CIP of 30 diopters. Now, because again, we want to correct this deviation, we're looking at what would a post-op correction cause. Will it give us double vision? What we're interested in is only presenting a base-out prism because the base-out prism is what's going to get us towards fovea. Let's say that this patient had a suppression scotoma between CIP and fovea. What we will find is that the patient with an undercorrection will have single vision, with full correction single vision, but with an overcorrection they'll have diplopia. And generally we aim to overcorrect by at least 10 diopters in this test. So this patient is at low risk of post-op diplopia. They have single vision with full and undercorrection, and so the surgeon would aim for either a full or undercorrection depending on what is desirable. Okay, let's look at another scenario. In this instance, we again have a left esotropia, but this time the suppression scotoma is short. It doesn't make it all the way to the fovea. Again, we're going to use a base-out prism because it's an ET. We want to move towards the fovea. But now what we'll find is that with an undercorrection, with a full correction, and with an overcorrection, the patient will have diplopia. So this patient is at high risk of post-op diplopia. The thing we want to know about is exactly at what point the patient appreciates diplopia. And also, when they have the diplopia, can they ignore it? Is it bothersome? Because you're trying to give them an indication of what it might be like with surgical correction. If the patient is at high risk of post-op diplopia, Botox may be a good indication here, where they get to experience what it may be like to have surgical intervention and then make a decision as to whether surgical intervention is desirable given that they may have this post-op diplopia. Okay, let's look at one other final example. So here I've given you a left exotropia in this instance, and what we have now is a suppression scotoma from the CIP extends to the fovea and goes beyond. So in this instance, we're going to only need a base-in prism because that takes us towards correction, moving towards the fovea. And what we'll find is that we have single vision with an under, single vision with a full correction, and single vision with a overcorrection. So this patient is not at risk of post-op diplopia. Okay, that brings me to the end of this video. Thank you.